So, Bismillah wa salatu wa salam rasulullah. Good evening, ladies and gentlemen. I'm very honored to introduce one of the Saudi Society of Blood Disorder webinar. It's a MENA Forum for Challenging Cases in Hematology 2020. We started on September 7th, 2020. We're continuing until March 2021. It's going to be Monday of the last Monday of each month. As you know, we started with Langerhans cell histiocytosis, then Waldenstrom macroglobulinemia management. Today we're going to talk about amyloidosis management. Next one will be plasma cell disorder on 30th of November. We're very honored to have national as well as international speakers about our challenging cases. I would like also to thank our sponsor, our platinum sponsor Janssen, and our gold sponsor Hikma. Today, I'm very honored to have three senior physicians talk about amyloidosis from different perspectives. Our first speaker is Prof. Giovanni Baladini. He's a director of amyloidosis research and treatment at University of San Matteo in Pavia, Italy. He's vice president of International Society of Amyloidosis. He has been involved in research for amyloidosis since 1994. He has many research which led to establish of the standard of care in treatment of amyloidosis, and he has been contributed to the introduction of novel agent in the treatment of amyloidosis. He has over 160 research, including recently blood published in the blood about daratumumab with Cyborg-D in the treatment of AL amyloidosis. Our next speaker is Dr. Dania Mohti. She's a consultant adult cardiology at King Faisal Specialist Hospital and Research Center, Riyadh. She's a professor of cardiology at Al Faisal University and University of Limoges, France. She had her medical school and residency from Montpellier, France. She did a fellowship in cardiac images from Tours, France. She has an echo fellowship at Mayo Clinic, Rochester, United States, and she did her PhD from Canada. She has been over 10 years in Limoges, France, as Center of Referral for AL amyloidosis. She has a special interest in cardiac images and heart failure. She has over 100 publications. Currently, she's a consultant and adult cardiology and echocardiologist at King Faisal. And our last, Dr. Amr Hanbali, he is a consultant hematologist and stem cell transplant at King Faisal Specialist Hospital and Research Center, Riyadh. He has graduated from University of Amman, Jordan. He is American board certified in internal medicine and hematology. He did his fellowship at hematology oncology at Henry Ford Hospital, Detroit, Michigan. He has been a hematology oncology fellowship program director at Henry Ford Hospital. He's a senior hematologist. He has a special interest in plasma cell decreases and AL acute lymphocytic leukemia. He had over 80 publications in plasma cell as well as leukemia. Our agenda today, we will start with definition and introduction by Dr. Giovanni Baladini. Then we'll go to clinical and multimodality approach for the diagnosis of cardiac amyloidosis by Dr. Dania Mohti. Then we'll have a treatment of AL amyloidosis by Dr. Giovanni Baladini. We have special clinical challenges and case presentation by Dr. Hanbali. Then at the end, we'll have around 20 minutes for question and answer. Please type your question and answer on question and answer at the site. Then we'll read it at the end of the talk. Please don't forget that this webinar is being recorded, so you can go back and listen to all of our Saudi Society of Blood Disorder webinar on YouTube. And don't forget to follow up at Twitter. So without any further delay, please welcome Dr. Giovanni Baladini, who will talk about introduction of amyloidosis.
Thank you very much for this very kind introduction and for the invitation. I am honored to be here amongst distinguished colleagues and with this wide audience that we have. In the first 10 minutes, I will introduce you to systemic amyloidosis. which is, of course, not a single disease, but it is rather a group of diseases. All of them are characterized by protein deposition in tissues, which causes organ dysfunction and can lead to death in the systemic forms of these diseases. We classify more than 30, actually 36 different types of amyloidosis. Of course, some of them are rarer, some others are more frequent, some are localized, others are systemic. So in our everyday, for amyloidologists, clinical experience, we can have this 6 most common types of systemic amyloidosis. AL amyloidosis, that is still the most common type of this disease, that can involve almost every organ with the exception of the central nervous system and is treated with chemotherapy. Then we have transthyretin amyloidosis. This can be wild type or hereditary. We can have amyloidosis reactive to chronic inflammation and other rarer hereditary types of amyloidosis, as well as the newly recognized ALECT2 amyloidosis, whose pathogenesis is still largely unknown. Well, as you can see from this chart, there is a substantial overlap between the clinical manifestations of these diseases, while, of course, etiology, that is the protein that causes the deposits, and hence treatment are largely different. So the differential diagnosis is extremely important to adequately treat these patients. Systemic amyloidoses are rare diseases, but they are not as rare as we can think of. This chart summarizes the most recent studies on the epidemiology of AL amyloidosis. And as you can see here, the annual incidence ranges from 3 to 13 cases for 100,000 person year, according to the conditions of the studies and to the populations and times the studies were conducted. In any case, in practice, what does this mean for the hematologists who are used to deal with patients with monoclonal components? Well, this means that if you have 5 to 10 patients who progress from MGUS to multiple myeloma, then you need to have at least 1 patient who progresses from MGUS to amyloidosis. If you have less than this ratio of amyloidosis to myeloma of 1 to 10, then there is something wrong in your screening and diagnosis process. This is very important because this makes us understand that it is not really such an extremely rare disease as we know, as we think sometimes. The epidemiology of cardiac amyloidosis, of systemic amyloidosis with heart involvement, is also changing. As you can see here, while the relative incidence of cardiac AL type amyloidosis is substantially stable in the last decades, well, wild type transthyretin amyloidosis, that was previously known as senile systemic amyloidosis, is actually increasing its incidence. And now you have a 50% chance of having AL or ATTR wild type when you see a patient with cardiac amyloidosis. So this is important for the cardiologists who are listening to us tonight. And the differential diagnosis between these 2 common forms of cardiac amyloidosis is extremely important because the different studies showed that up to 49%, approximately 1/3 of patients who actually have senile systemic amyloidosis, that is non-AL amyloidosis, do have a monoclonal component. So when you have a monoclonal component, you need a tissue biopsy to diagnose amyloidosis. And tissue typing with adequate technology is also mandatory. But other speakers will come closer into details on the diagnostic process of cardiac amyloidosis and systemic amyloidosis in general. Just a brief review of the mechanisms of transthyretin amyloidosis. Transthyretin is produced by the liver, and this protein has an intrinsic propensity to form amyloid. This can be increased by mutations in the hereditary forms of amyloidosis, but also wild-type TTR can deposit in tissues in the form of amyloid. This is the pathogenic cascade that produces amyloid deposits, and each step, as you see, can now be targeted by treatments. So we do have treatments for TTR amyloidosis. In AL amyloidosis, we have a clone, a plasma cell clone, that is usually small-sized. Approximately 50% of patients with AL amyloidosis do not qualify for multiple myeloma, that is, they have less than 10% plasma cell infiltrating the bone marrow. This clone produces an unstable light chain that can cause a direct proteotoxicity on the organs and forms amyloid deposits. And this is the organ involvement that you can have in AL amyloidosis, with the heart and the kidneys being the most commonly involved organs. So the clone is different from that of multiple myeloma because it is smaller in size, but also because it has a different proportion of cytogenetic abnormalities. The most common chromosomal abnormality in AL amyloidosis is translocation 11-14 that can be found in up to 50% of patients and is associated with poorer response to bortezomib and immune modulatory drugs that can be overcome by high dose and oral melphalan. 20% of patients have a gain of 1q21 that is associated with poor response to oral melphalan. I have briefly mentioned organ toxicity of the circulating precursor. This is very relevant because in clinical practice, if we can quickly reduce the concentration of the amyloid circulating precursor, that is the monoclonal light chain, we can induce rapid organ improvement, and we can see this with cardiac biomarker. In this patient that was treated successfully, the decrease of the monoclonal component was associated with a decrease in the cardiac biomarker NT-proBNP, and this was also associated with improvement in heart failure. Then there was a progression of the monoclonal protein of NT-proBNP and a progression also of heart failure. During the observation, the amount of amyloid deposited in the heart, as assessed by echo, remains stable. Indeed, we have some animal models that explain us that cardiac toxicity is associated with the precursor rather than the deposits. In isolated mouse hearts, when you infuse light chains from patients with cardiac amyloidosis, you immediately obtain an increase in diastolic pressure without amyloid deposits. In a model of C. elegans, that is a worm whose pharynx pulsates rhythmically in analogy to the vertebrate heart, the pharyngeal rate decreases when you challenge the worm with light chains from patients with cardiac AL amyloidosis, and it is not so with renal AL or multiple myeloma. If you inject light chains from patients with cardiac amyloidosis in the heart of the zebrafish, then the cardiac output of the fish decreases, as well as the lifespan of the fishes. So there is definitely a toxicity of the circulating light chains that explains why, if we reduce the light chains with chemotherapy, then survival is much better. The pathway by which this toxicity is exerted involves the p38 MAP kinase in the cells, but it is also the same pathway that induces the synthesis of BNP. And this is why NT-proBNP and BNP are so important markers of cardiac dysfunction in AL amyloidosis. But the light chains that form amyloid are not only toxic for the cardiomyocytes, but they are also toxic for the plasma cells. In a model of non-secreting mouse plasmacytoma that was engineered to produce either multiple myeloma or AL amyloidosis light chain. We observed that the production of light chains from patients with AL amyloidosis in this model was associated with reduced cell viability and increased sensitivity to bortezomib. So the plasma cell used the proteasome to cope with the toxicity induced by the light chains they themselves produce. And this is important because we can exploit this for targeted therapy. In conclusion, we have a group of diseases that have overlapping clinical presentation that depends on organ involvement. We should be aware of this for differential diagnosis. AL amyloidosis is not so rare, and you need to have at least one patient with AL amyloidosis if you have 10 patients with multiple myeloma. And light chain toxicity explains most of the organ dysfunction in AL amyloidosis. Thank you very much.
Thank you, Dr. Baladini, for the introduction. Now we'll go to Dr. Dania for her cardiac amyloidosis.
Assalamu alaikum. Just to make sure that you are seeing my screen again.
Yes.
Thank you. Assalamu alaikum. Good evening, everybody. Thank you very much for this kind invitation. Actually, this is, sorry, I just need to start this. So I don't have disclosure tonight for this talk, except that it was my first time being with hematologists, at least in such a big audience in Kingdom of Saudi Arabia. And as Dr. Saud told you, who kindly introduced me, I work with Professor Arnaud Jacquard, my friend, for 10 years on where my home was in Limoges, which was the referral center, National Center for Light Chain Amyloidosis and Rare Other Hemoglobin. But actually, I was involved in this disease actually when I was a kid, when I was medical student since 1993, because I lived with someone who was dying from cardiac amyloidosis with light chain, which was my mom. And this is our first publication from my brother. So don't think there's a conflict of interest with my brother. My brother does not even know that I'm with you tonight with the hematologist. And so basically I was really affected by this disease long time ago, because she died unfortunately unless she had her heart transplant done very, very fast, 3 weeks after that. And then in 2018, just to, we tried to work with our colleague from hematology, from nephrology, and we tried to have like a amyloid team, we call it an amyloid team since 2018, when after this ATTRACT big trial came out on the ESC, and we are trying hopefully to have more and more diagnosis done in Kingdom of Saudi Arabia in our hospital. So I want just to have 1 minute to tell you why we did not diagnose this cardiac amyloidosis easily so far, because actually what the eye does not see, what the mind does not know, and what we see depends mainly on what we're looking for. So far, when I asked my colleague in Saudi Arabia, when I arrived here 3 years ago, and I asked them, can we work with amyloidosis? They told me, we don't have amyloidosis here. I said, how come we have in Europe and we don't have? They said, no, focus please on disease. We don't have amyloidosis in our country. So later I tried to convince them that there is, and we found eventually a few of them. And actually the problem is not even in Kingdom of Saudi, and this is consortium research done by PhD, which was herself a patient who survived from light chain amyloidosis, and she made a survey of 500 participants, family or family member, and she really found exactly what are the main reasons why we did not diagnose this patient. And she said that in 40% of the cases were from this participant, correct diagnosis was not established until more than 1 year after the onset of the symptoms, and it took more than 2 years in 20% of the case to diagnose the light chain 1, and more than 4 years for the ATTR. The diagnosis was not made easily unless they visit at least 4 physicians, and including a psychiatrist. And I lived that in Limoges, when people sit down in the echo lab and tell me, people think I'm psychiatric and I have many complaints, and nobody believe on me. And even in cardiologists will think they are good on that. The correct diagnosis was not made actually, except on 19% of the case, despite advanced stage of the disease, which I saw you really historical images of cardiac amyloidosis. diagnosis. But my problem is not only that, is that this is this is really a recent study from Switzerland. We consider Switzerland as a really high income country and very developed. And this they ask and they make a survey for the physician. And believe or not, they were not aware of the disease. And actually they did not know, for instance, the pseudo-anthrax pattern was found on the things they should look for on the EKG. The Centigraphy was not even mentioned in this survey, meaning that there is lack of awareness of the diagnosis and the tools to diagnose cardiac amyloidosis. So the problem comes from many problems. And as Dr. Giovanni told me, amyloid is a systemic severe disease, which is misdiagnosed, underdiagnosed, because it's not a straightforward diagnosis or easy. And Dr. Claudio Rapezzi used to say always, it's a great pretender and a simulator. Several myocardial disease actually can phenocopy cardiac amyloidosis for us as a cardiologist. And despite novel therapy, the prognosis remained bad because of the physician-related factor, low awareness, fragmented knowledge, disease-related factor, lack of knowledge, big variability of the phenotypes, advanced organ dysfunction when that diagnosis is made, and also the wrong conception that is an untreatable disease. So people will tell us, why should bother and diagnose this disease? And therefore, the most important parameter here is to have a high index of suspicion and to use an integrative approach using clinical clues, EKG, multimodality imaging, which is mandatory to reach the correct diagnosis. So as Dr. Giovanni told me, I will not go into details. He told you mainly there is a lot of precursor protein capable of forming amyloid fibrils. Here I summarize for you the most important thing for us, the light chain, which he will talk later also about it, and the ATTR1, which could be hereditary or acquired, and both of them will lead to deposit of either mutant transthyretin in the different organs or wild type transthyretin. And of course, you have the other type, that is the post-inflammatory one, which I will not talk about it today. There's the cardiac involvement is rather rare. And as he told you, there is not only one amyloidosis, but many amyloidoses. So it's it's so crucial to make the correct diagnosis, not only the amyloid presence, but also the typing of the amyloidosis, because if you treat somebody with chemotherapy who has TTR, you may kill him, and vice versa. So really we need to know what type of amyloidosis we're dealing at. So the mechanism of amyloidosis, he told you about it, about the light chain and the white top, so I will go faster, and the importance of having the genetic and the correlation with the phenotype in mutant TTR, because some of the mutation will give a mixed phenotype, means neurological and cardiological, and some of them will be more prevalent for the neurological features, and some others, like the American mutation, will be more predominant on cardiac features. So it's really important, and I will show you the role of genetic testing on the latest algorithm we made here. So the common, he told you that usually we used to say always that light chain amyloidosis is very common, and we have mainly 60% with cardiac involvement. But now, actually, I can show you, and many studies will show you that the ATTR amyloidosis will be the most common in the world because of the elderly patient and the prevalence becoming very diagnosed on the F5 population, which is very prevalent, 15% of them, and 15% of the aortic stenosis patient. And we know that both diseases are really epidemic in the elderly population. The wild type is different from each country to country. There is epidemic area in Portugal, Sweden, and in Japan. So I will show you that the main pillar of multimodality approach are the EKG, the echo, sometimes the MRI, the lab test, the role of biomarkers, and Dr. Giovanni will also add a lot of things about biomarkers, and of course the bone scintigraphy. I will talk a little bit about the role of tissue biopsy, sometimes the heart biopsy, and once the diagnosis is reached, then we can treat. So what are the different heights and clinical red flags? The age is really important. It can help us. Usually the light chain present in patient age more than 50 years. The median usually at the retirement, people sit down and they start thinking about their disease, and they start thinking they are losing weight, they are fatigued. Really all the patients I've seen, most of them, they arrived after they take their retirement. And actually it's the same prevalence in all countries. However, the wild type 1 is also usually present in patients more than 65. The median age is more around 75 years old, is much more frequent in men than female, and any country where life expectancy is more than 70 we should find this kind of disease. As I told you, for the ATTR, could be any age according to the type of mutation. You have early onset cardiac versus late onset, but usually one must know that neurological manifestation precede by average 5 years the cardiac manifestation. So if somebody comes with neurological or neuropathy or unexplained something, we can expect that we should look for early cardiac involvement. Now the red flags, in addition to the cardiac, which are very common, in any heart failure patient, you can have dyspnea, fatigue, weakness, right side, most of the time pedal edema, ascites. In 50% of the case, patients will present with atrial fibrillation or even a cardioembolic event, even sometimes in sinus rhythm. I will show you why. And sometimes people who are hypertensive, they will start having low or normal blood pressure, requiring reduction or even discontinuation of antihypertensive therapy. Now, if you want to make some difference between transthyretin and light chain, I put you like roughly is not completely totally correct, but you can see that the lesion, the skin lesion, the periorbital purpura are more frequent in light chain, the macroglossia, the hypotension, orthostatic hypotension, the pseudohypertrophy of the deltoid, the frequency of edema, the nephrotic syndrome, massive proteinuria that are more common in light chain, whereas for the transthyretin, you must expect more presence of carpal tunnel syndrome, peripheral neuropathy, low flow, low graded aortic stenosis, male presenting typically more than 65 years old, and also atraumatic tendon rupture, biceps tendon rupture. As you can see here, the patient has not have pain, and you can just do this sign by showing, as I show you here. This is from Pablo, nicely given to me. So basically, you can look at other non-specific signs. The unexpected depression. I have seen many patients coming with depression, fatigue, significant weight loss without even doing any diet, ageusia, diarrhea, constipation, erectile dysfunction. Most of these things are in light chain amyloidosis. Unexpected intolerance of first-line heart failure medication. People are very surprised. The cardiologist says, I'm giving him everything. I'm giving him the state-of-the-art treatment, and still this patient is worsening and is not improving. Unexplained syncope also, and many other things that if you put them together, like in this paper, actually I'm happy I found it yesterday. It is still in press, not even published, and you can see here in green the most common sign for the light chain amyloidosis: liver involvement, renal involvement. Basically, when you have renal involvement, you can see that you have cardiac involvement, that's roughly the same, 60 or 70, something like that. And the common things are the cardiomyopathy, 60% versus 90% for the wild type. The carpal tunnel, the GI symptoms are common in both. The peripheral neuropathy also, but macroglossia is more often found in the light chain, and the erectile dysfunction and the sexual dysfunction in both. Now, as a cardiologist, where should I look for this patient? Actually, 35% of the cases were hidden behind this benign diagnosis of hypertensive disease. This is a case coming from France. It's a 56 years old female. She has a history of hypertension, and she has a workup for proteinuria. Usually, unless you have a very severe hypertensive disease, you don't have this proteinuria so early. She had mild dyspnea, NIHA class 2, that blood pressure was correct, and she stopped her medication, and that the NT-proBNP was high, 1800, and the troponin was negative. So basically, as we know, as a cardiologist, usually you don't have really a specific reason for classical hypertension to have so much increase in BNP. So this is a red flag for you that this lady is presenting with something else hidden behind the hypertension, and we'll talk about this echo sign. I know you are not cardiologist. I'm very passionate about echo, and I cannot help myself do a topic or a lecture without echo. This is a left ventricle. You can see this is a mildly hypertrophied or thick heart. Let's see, this is the left ventricle, this is atrium enlarged, and this patient has normal ejection fraction, but you can see that the valves are thick, and I will show you. And this is what we call the sparkling appearance. We don't believe anymore on this because it depends on the machine, it depends on the harmonics and the gain, but there's other sign that I will show you later about it. So as Dr. Giovanni told you, extra cardiac sign will improve the positive predictive value of echo, as any organ could be potentially involved, the kidney and the heart equally, the nerves. If you have a cardiac involvement and nerves, neuropathic, peripheral neuropathy, think of hereditary. And if you have mainly the heart, think of wild type TTR. Now, if you have to pick up 3 simultaneous manifestations as a cardiologist, I have somebody who's presenting with heart failure and nephrotic syndrome and neuropathy and other signs, but this is 3, think it's an light chain amyloidosis until otherwise proven, and give yourself only 1 week to make the diagnosis, because really it's an emergency, exactly like we have aortic dissection for us. That's why systemic amyloidosis cannot be managed solely. You have really to have a multidisciplinary team, which we try to have in each country. And I think Europe has succeeded to do that because they work always as a network. There is a lot of benefits to work as not only a team in one hospital, but also as a network approach in the whole country, versus even though because of the increase of awareness and education, the increase of screening, the facilitation of research, the collaboration, and the access of the treatment, which sometimes is expensive. So for the EKG now, it's the first contact for us with the patient after the clinical examination. This is a typical case of low QRS voltage, as you can see here. I know that you are not cardiologists again, but this is, I think, you can see it even when you see your patient. It's very common in light chain amyloidosis in 60% of the case, less frequent in ATTR, 25% of the case, but it's not enough or specific or sensitive. It means if you don't have low voltage, it doesn't mean that you don't have light chain amyloidosis, because in this study, you can see here, the low voltage was present only in 35% of the case. So if you're only expecting to find low voltage, you will miss a lot of diagnosis with light chain amyloidosis. Now, which important, I think, it's the discordance between the LV wall thickness that we found in the echo and the QRS voltage. This QRS is maybe normal by itself, absolutely, but when you compare it to the thickness of the heart by echo, then you will see that there is really a ratio between the hypertrophy with the heart and the LVH, which are not combined together. So the QRS voltage here, you cannot interpret it unless you have the echo with you. I always say to my colleague, please put the EKG and the echo together if you want to make the diagnosis of amyloidosis. And this has been shown in many studies, this ratio of QRS voltage to the LV wall thickness divided by the mass, which is here, you can see it for the amyloid patient and unusual for the HOCM patient. Now, the pseudo-infarct pattern, this, as you can see here, really is somebody has absence of the coronary artery disease or history of chest pain or no regional wall motion abnormalities, and you still have this V1, V2, V3, like we call it the pseudo-infarct pattern in V1, V2. Think of ATTR amyloidosis. It's present in 70% of the case and may lead actually to us. But what's unstable on the time and with low level of troponin, then we should think that it's not coronary artery disease, but rather something else, especially if you have LVH. Now, of course, the other findings are arrhythmia are very common, and the conduction disturbance, because the fibril deposit go within all the system. It does not discriminate between the myocardium, between the valves, between the system, the conduction system. So you can expect to have almost 50% of the case will present with atrial fibrillation because of the dilatation of the left atrium, and you will have left bundle branch block or RBB like in this population, and some people were found after an implantation, unexplained implantation of pacemaker. So really, it's really common in ATTR, but also in light chain amyloidosis. What is the role of echo? The echo is really the queen for everything. It has a very good sensitivity, of course, lower sensitivity comparing to other, but at least it will give us a first clue, morphological clue, hemodynamic clue, diagnostic and prognostic information. I will talk about this important sign that I'm showing you all the time here. So the definition actually of cardiac involvement, according to Dr. Giovanni's consensus paper in 2012, you can see that the wall thickness by echo more than 12 is very important, but because it's not very sensitive and because people who knows how we do echo, it's not really, the M mode is not very precise. When I say 12, it could be 10, could be 11, could be 13. So they added on the consensus paper to increase of BNP or the troponin to make sure that this increase of wall thickness in the absence of other cause is related to light chain amyloidosis. But typically the diastolic heart of amyloidosis has been described here by Matthew Morer as typically diastolic heart failure. The problem is if you expect this, what we call the restrictive cardiomyopathy, again from the same paper from Quarta, you will see if you are expecting only a restrictive pattern, you will miss a lot of patients. In fact, most of the patients can present with impaired relaxation or earlier stage and restriction or having like almost dying or peripheral or pulmonary edema. The most important, I think, the sign will be to look for abnormality on the longitudinal or deformation of the heart. I will explain for you what is this in 1 minute. So basically, all type of mitral and filling pressure could be found, pseudo-normal or normal pattern or type 1 or restriction. Most of the people, when we study on the medical school, they always tell us is restrictive cardiomyopathy, it will give. But this will occur, actually will occur at very late stage of the disease. So the most important, I think constant, what we found all over the years is the E/E prime ratio that are always increase, almost increase, and the S, which is actually here another way of expressing the longitudinal, the decrease, the destruction of the longitudinal function at the basal level by the deposit of the amyloid fibrils. This paper is very, very important, and this is really a concept. It proves the concept what has previous study have shown the relation between the HFpEF patient, the heart failure with preserved ejection fraction, and the presence of amyloid prevalence. And this paper have shown us that exactly the same prevalence here. This is by heart biopsy. I'm not saying that we should do heart biopsy for everybody, but this was a really paper for research purpose. They found exactly 14% of patients who presented with HFpEF, means heart failure with preserved ejection fraction, and the characteristic of this patient had older age, lower blood pressure, lower BMI, lot of comorbidities, elevated NT-proBNP, elevated troponin, and high LV mass. And actually, when you look at the type of amyloidosis here on their series, you can see the light chain was present in 20% of the case, and most of them were 50% were wild type, the senile one. We call it the senile because before it comes at the elderly age, but now we don't call it anymore senile, we call it wild type. Okay, so in the other case was hereditary. So this is important, and as I told you, it confirms all the previous series from Spain, from Italy, from France, showing you that almost 15 to 20% of our population who will come to the emergency room with a diagnosis of HFpEF, in 20%, every 100 patients, we have 20 who had amyloidosis. That's why I'm telling you it will be an epidemic in few years. If really we look at the diagnosis, we will find them. This is a typical case I bring with me from France. Really, I will never found such more evident and obvious case of all involvement. The valves were involved. The heart was very, very sick. One wonder how she could survive so much. Usually we say they will not become so thick for this woman for light chain amyloidosis, but look at her history. She was 67, diagnosed as HFpEF patient since 2 years by a private doctor, but she had rapid deterioration despite optimal treatment since the beginning, and the NT-proBNP was very, very high, more than 25,000, and the systolic blood pressure was less than 90 millimeter. And of course, this lady, as soon as she arrived to Limoges, we made the diagnosis of light chain, and unfortunately, she was stage 3B of the Mayo Clinic European classification, and she died within 6 months despite all the treatment because she was very, very advanced of the disease. And despite that, as you can see, the doctor did not diagnose it very soon. And this belongs actually to this series of patients, NT-proBNP more than 8,500, systolic blood pressure at presentation less than 100. This patient will really, really die within the stage 3 of the Mayo Clinic. They will die very, very fast, as you can see, and we don't want to see that anymore. This is another case. You can tell me, Dania, you bring a case from Europe, but this is a case from King Faisal, and you can see here the NT-proBNP was more than 70,000. I am a cardiologist. I have been working for the last 25 years. Very rarely the dilated cardiomyopathy or the heart failure, our heart failure patient will present with so much high NT-proBNP. So when you have so many high, usually they present with 5,000, 6,000, 7,000. But when you have so much high imports of NT-proBNP, think of other things behind the diagnosis of you can see here, this again, same story of Madame Squarneck. She has low ejection fraction at this stage, dilated atrium here, and you can see here, even the right atrium, actually here, the RV free wall was very, very thick. Means, again, the amyloidosis is blind. It does not discriminate. It will go everywhere. And you have this in 50% of the case, this small pericardial effusion. Our patient, they don't have usually this small pericardial effusion unless they have a reason for that. And despite despite inotrope diagnosis of severe cardiac light chain amyloidosis was made, but expired within a few weeks also because she arrived really at a stage of electromechanical dissociation. The other diagnosis where we can find this patient as a cardiologist are hypertrophic cardiomyopathy, the sarcomeric one, the one you know, that the familiar sarcomeric one. And this paper from my friend Thibaut Damy from France in the European Heart Journal found that almost 8% of the people more than 55 years old who were previously diagnosed as sarcomeric cardiomyopathy, hypertrophic, actually they have the mutation of the TTR. So basically, we don't diagnose like suddenly we awake in the morning at 60 years, we have sarcomeric. Usually the sarcomeric one arrive at 20, 25 years old with a family history of hypertrophic sarcomeric. So every time you have somebody who present with hypertrophic cardiomyopathy as a later stage, think of ATTR amyloidosis. Now, what are the other way we can find this patient? Look at this patient. Again, you can see sick heart. I think at the end of the talk, you will be a cardiologist yourself. This is a very sick heart, very small ventricle, does not move a lot. However, if you calculate the ejection fraction, you say, oh, it's around 50%, but actually it's not moving really much. The valve is very sick, and this patient actually have severe aortic stenosis, but low gradient. The heart is too weak to generate any gradient across the valve, and that's why we call it low flow, low gradient aortic stenosis. And actually, if you put the information together, again, put the EKG, look at V1, V2, V3, this patient has no coronary artery disease, look at this small ventricle with really appearance, look at this cherry on top with the strain, and look at the gradient and this valve, and if you put them together, you will find the diagnosis easily, which we described already in 2016. This was a multicentric study, again, with my friend Thibaut and all other colleagues. These are associations between aortic stenosis and cardiac amyloidosis. And we call it recently the 2A dangerous lesion, aortic stenosis and amyloid heart disease. And basically, after this publication, all the population from all Europe and United States and everywhere, they start looking at their data, and they found exactly this kind of association. And basically, if you summarize the literature, the prevalence of cardiac amyloidosis in aortic stenosis patient is around 5% of those who are undergoing surgical aortic valve replacement, whereas it's around 15% for those who are TAVI. Why TAVI? TAVI is transcutaneous because these patients are old and they will not survive to surgery, so we send them to percutaneous intervention. So this patient, elderly patient, think of them every 100 patients. They are very, very numerous. It's a big disease. You have 15 of them, they have amyloidosis. And this is, we did a topic with my friend from Quebec, aortic stenosis and cardiac amyloidosis. There are some red flags. Now, I keep talking to you about global longitudinal strain. Again, this is a patient who died very fast. This patient present also with severe cardiac light chain amyloidosis at advanced stage. You can see that the ejection fraction is around 40%, 35. But what's common about this patient is this type of pattern of strain. So I know that you will not do it yourself, but if you ask your cardiologist, I'm looking for amyloidosis, please do the GLS for me, they will do it for you. All the machine can do it. It's actually an expression of the deformation of the myocyte. The longitudinal deformation is very robust, and it has been shown that it has a very good sensitivity to diagnose cardiac amyloidosis as compared to other disease. Every time you have amyloidosis, you will have, I'm not saying every time, but most of the time, in the absence of kidney disease or really is 93 sensitivity to have this cherry on top. The apex will be preserved. Usually red means everything is good, the deformation is good. When you have pink or blue, it means that it's not contracting, the heart is not moving, okay, because of the febrile amyloid. Each type of disease will have a different pattern, but for cardiac amyloidosis, look always at this pattern, whether it's at a late stage at this patient, the GLS normal is -20, but also at earlier stage, this patient has -17, but still you can see the difference between the basal level here and the apex. The apex for some reason will be preserved because probably the fibril will deposit on the basal level of the heart and they will not go until the apex. But it doesn't mean that the patient at late stage, they will have also lower in the apex, but still the difference, the ratio between the apex and the base will be different. Okay, so there's other signs here. I summarize for you the decrease of the stroke volume, again, because the heart is too weak to generate any stroke volume or cardiac output. You have the thickness of the valve that are marker of the disease itself, not a marker of severity of the regurgitation. You have this atrial dysfunction that is not found in other disease, hypertrophic cardiomyopathy. You have this high LV filling pressure and thick RV here, and you can see that all has been shown to have a prognostic information. We have shown also even in MRI that when you have involvement of the left atrium, you have also actually deposit on the left atrium, which is contribute also to the left atrium dysfunction. And this is explained why this is basically the only disease where patients remain in sinus and still they can have thrombus and they have thromboembolic event. So really think of it, because the atria does not move. As I told you again, the amyloidosis is blind. It will deposit everywhere. It will deposit on the left atrium, and this atrium does not move, not only because of the high LV filling pressure, but also because of the intrinsic deposit of the light chain amyloid or the amyloidosis fibril itself.
Dr. Dania, 2 minutes.
Yes?
2 minutes, please.
2 minutes? Oh, okay, sorry. So can we differentiate light chain from TTR? Yes, because they are thicker for the TTR and they are less thick in the light chain. Usually they are much higher. Now, this is another example of somebody who has TTR, very thick and long stage of the disease over 12 years. I will go stop there. I will go. The role of CMR, sometimes we have to do CMR when the echo is not informative, because there is correlation between LGE by CMR and amyloid interstitial deposit. All type of patterns of distribution of the LGE are found on the heart. And actually the T1 mapping is very informative in this type of the disease as comparing to the other, and it's higher in ATTR rather than light chain amyloidosis. The reflex, I will, if you want, we can do it in the discussion. When to perform a bone scintigraphy, I think please give me 2 minutes. It's very important for the scintigraphy. This is a very easy test that can be done by any radiologist. We have to do planar but also SPECT imaging to make sure that the uptake, the tracer uptake is in the myocardium and not in the blood. Okay, this is, you have 4 grade, grade 0, grade 1, when you don't see the uptake, grade 2 or grade 3, which is sign is uptake, significant uptake on the heart. You can also doing by quantitative, by doing this ratio. Now, if you have a grade 2 or 3 by bone scintigraphy and absence of plasma cell dyscrasia, this is really diagnostic of ATTR with a positive predictive value of 100%, and basically we don't need tissue biopsy for the ATTR. When we need a tissue biopsy, basically, sorry, I'm going fast because he stressed me out now. Oh, I'm stressed now. Oh my God. This is, I think, Dr. Giovanni will talk to you about the prognostic information of biomarkers, but basically, I told you a lot about the BNP. Actually, there is intrinsic secretion of NT-proBNP because of the toxicity of the light chain on the myocyte, different of the systemic secretion of BNP. Now, okay, I will go through this one. No, for the light chain, when you have to do the biopsy, I think he will tell you about it. The biopsy are important and crucial to prove the presence of amyloid fibrils every time you're suspecting light chain, and it should be always do by either glandular salivary gland or rectal. And the typing of the origin protein is very important. Otherwise, will be mixed between TTR and light chain. We have to do mass spectrometry. So we have to document the amyloid infiltration, and we have to provide definitive etiology classification of that. Now, this is very easy, but I think Dr. Giovanni will touch a word about the sensitivity of the abdominal fat, and if you added it also to other rectal scat, in 85% you will find the fibril amyloid on the peripheral tissue. When we should perform genetic testing to differentiate between ATTR and the other type of amyloidosis, and you have to differentiate with the wild type and hereditary for family screening. So overall, in summary, where we should look for this cardiac amyloidosis: on the HFpEF population, on the aortic stenosis population, on the nephrotic syndrome clinic population, in the duly diagnosed HOCAM population, and other in the canal turper syndrome population, and also even in cancer patient with incidental uptake on the scintigraphy. So in summary, I will show you the algorithm, and this will be my last slide. If you have a clinical assessment, blood test, echo, CMR, and EKG, which raise the suspicion of cardiac amyloidosis, please perform bone scintigraphy of the heart. If the heart scan is positive, grade 2 or 3, then you have to perform workup for monoclonal gammopathy. And this, if it's negative, then you have to think of TTR amyloidosis, and you perform genetic testing. If the genetic are negative, you are dealing with wild type. If it's positive, then you're dealing with hereditary TTR. There are many algorithms actually in the literature, but this is one we did in King Faisal. If you have a negative scan or equivocal, grade 0 or 1, because I did not tell you that in 10 to 20% of the case, light chain could also fix on that. So you have still to do the workup for monoclonal gammopathy. If it's positive, then you have to do an urgent tissue biopsy. If it's positive, then it's light chain amyloidosis. If it's negative, then it could be AMGAS, but this is Dr. Giovanni will talk about it. And if it's negative, then it's no amyloidosis or maybe other type of amyloidosis. And again, do a CMR or sometimes a heart biopsy for that. What are the therapeutic options? I will not speak about the specific treatment, only general principle: avoid hypotension, avoid bradycardia, avoid worsening of heart failure by our classical medication, give Lasix, aldactone, avoid all the things so that make people bradycardia, and don't use ACE inhibitors, don't use digoxin, don't use channel blocker. This is what make worsen people. And in the opposite, when you stop them, people decrease their BNP and increase their 6-minute walk test. This is the chat stop. Again, I will not talk about it. It's just to remember the chat VASC. The specific treatment is to stop the infiltration process and decrease or stabilize the organ damage. And the take-home message from how have a high index of suspicion. If you don't think of it, you will not diagnose it. Cardiac amyloid is not a rare disease anymore. Look for red flags on EKG and echo simultaneously. CMR should be ordered if echo is not contributive. Extra cardiac findings improve the imaging findings. Bone scintigraphy and electrophoresis protein and immunofixation are crucial for the diagnosis of cardiac amyloidosis and distinguishing between light chain and TTR. Tissue biopsy is mandatory for light chain confirmation and rarely endomyocardial biopsy. An integrative approach is needed. Thank you very much, and sorry for the delay. I was trying to be fast, but I couldn't do more than that.
Thank you very much, Dr. Adani. Very impressive and very elegant talk, covering everything from hematology to cardiology. Really, thank you very much. Now we'll go to Dr. Baladini and talk about treatment of AL amyloidosis.
Hello again, and congratulations for this wonderful presentation. I would have loved to have the opportunity to have more time. Anyway, in the following 25 minutes, I will discuss with you the management of patients with AL amyloidosis. We will now focus on AL. The problem in managing AL amyloidosis is that this is a very heterogeneous disease. So we have many different groups of patients that can be stratified best in a very accurate way just with cardiac biomarkers. That is, just with one blood test. You measure NT-proBNP and troponin, and according to the levels of these two biomarkers, you can distinguish these four very different groups with extremely different survivals. Patients who do not have heart involvement, stage 1 patients, enjoy a very good survival. They need to develop heart involvement before they are at risk of death. Yet on the other hand, patients who have very severe, very advanced heart failure have a median survival of only 5 months. So this is a hematologic disease whose survival is determined by the severity of heart involvement. We have one more staging system that, along as NT-proBNP and troponin I or T, also uses the free light chain burden, that is the burden of the toxic protein. And again, you can see that with these three biomarkers, you can differentiate 4 groups with very, very different survivals. Of course, the lower the level of the toxic protein, the better. And patients who have very, very low levels of free light chains enjoy a very good survival. In the long term, Also, the extent of bone marrow plasma cell infiltrate has a role, and those who have a higher than 10% BNPC have a poorer outcome. We can stage also renal disease very effectively, just considering proteinuria and glomerular filtration rate. So you see that there are very different groups and that patients with advanced disease here have a 50% risk of requiring dialysis within a couple of years. So it is remarkable that both with cardiac and renal involvement, you have stage 1 patients who have a very, very good outcome, irrespective of treatment. So this emphasizes the need of having a very early diagnosis. But let us move to management. The first note I would like to share with you is that treating patients with AL amyloidosis is much, much different than treating patients with multiple myeloma. This is because here, patients with AL amyloidosis are at risk of death early in the course of the disease. They die due to organ involvement. They do not die due to the hematologic malignancy. So if they enjoy a profound response to treatment, if they attain complete response, then their survival can be extremely long compared to patients with myeloma, that is a malignant cancer, who are bound to relapse. So we can make some consideration and reflections based on this difference. We should not plan long-term treatment strategy in AL amyloidosis because we just need to go out to the risk period of the disease, so the first few months. We have to adapt our treatment strategy to the risk level. We need to be delicate in treatment, but very aggressive in the follow-up in order to be ready to switch to rescue treatment early, patients who do not respond to upfront treatment. The target of our treatment is the plasma cell clone, and we are borrowing many agents from multiple myeloma to target this plasma cell. And we have a marker that is the circulating free light chain, that is not only a marker of the burden of the disease, but it is also the agent that is causing the disease, because it is the light chain that damages the organ directly, that causes directly organ dysfunction. If we succeed in reducing the concentration of the free light chains under a threshold that is different in different patients, then we can improve organ dysfunction. And we can monitor improvement of organ dysfunction, again, with biomarkers, BNP for the heart, proteinuria for the kidney, and alkaline phosphatase for the liver. If we gain a hematologic response, we increase survival. If hematologic response is associated with organ response, then you see here more than 70% of our patients can survive 5 years or longer. The major and first step forward in the treatment of AL amyloidosis was borrowing stem cell transplant from multiple myeloma. But we all know very well that patients with AL amyloidosis are extremely frail, and most of them are not transplant candidates. In this study, published in 2013, the Mayo Clinic very elegantly showed that all the early deaths that we were seeing with stem cell transplant in AL amyloidosis were seen in patients with elevated cardiac biomarkers. These patients should not be offered stem cell transplant. Indeed, the improvement of the eligibility criteria for transplantation over time was associated with a progressive reduction of early mortality. But this reduction in mortality was not observed in patients with cardiac amyloidosis. And now, these are the selection criteria used in the major amyloid center worldwide. Patients with advanced heart involvement are not candidates for stem cell transplant. In patients who are eligible, stem cell transplant is extremely effective. You see almost an 80% good, profound hematologic response rate in the patients treated more recently. Patients who attain complete response after transplant can enjoy very long survival. You see here a plateau after 14 years in the study from the Boston University group, and maybe some of these patients were actually cured. What's the role of bortezomib-based treatment before and after transplant? We know that patients who have a relatively high bone marrow plasma cell bulk do benefit from induction therapy. And induction therapy can improve organ dysfunction and make eligible for transplantation patients who were not eligible in advance. Induction therapy independently increases progression-free survival after transplant, but we can achieve high rates of deep and durable hematologic responses with bortezomib induction alone. And in Italy, we do not transplant patients who attain complete response after induction, but we use rather a sequential response-driven approach, offering transplant only to patients who do not respond satisfactorily to bortezomib-based induction. Bortezomib can be used after transplant as well, improving the complete response rate to up to 60% and improving progression-free survival, particularly in those who do not attain at least very good partial response after stem cell transplantation. However, most of the patients with AL amyloidosis are not transplant candidates, and they are usually treated with bortezomib. The National Amyloidosis Center group in the United Kingdom published the largest series so far of patients treated with bortezomib. And with this drug, the overall hematologic response rate was 65%, with almost 50% satisfactory deep hematologic responses. So, which is the preferred non-transplant therapy in AL amyloidosis now? The only trial that we have compared the previous standard of care, oral melphalan dexamethasone, with bortezomib, melphalan dexamethasone. And we observed that the overall hematologic response rate was higher, 81%, with BM-dex. And this did translate in an advantage in overall survival. This is remarkable. This was a completely academic study, a non-sponsored study. And we were able to document an improvement in this very robust endpoint, of course, that is overall survival. What do we know for the best association of bortezomib? We know that patients who harbor the translocation 1114 do not respond well to bortezomib, cyclophosphamide, and dex, on bortezomib and dex, and have poorer survival, while patients who have the gain1q21 respond poorly to melphalan alone, and the BM-dex can overcome the effect of both unfavorable cytogenetic abnormalities. And also exposure to both melphalan and bortezomib can prolong time to retreatment. But there is a game changer, that is daratumumab. The meta study was presented, the results were presented for the first time at the meeting of the European Hematology Association. This was a very large international phase 3 study comparing standard CyBorD, cyclophosphamide, bortezomib, and dexamethasone, with CyBorD plus daratumumab. And the results were remarkable. This is the largest phase 3 randomized trial ever completed in AL amyloidosis. The overall hematologic response rate was much higher with the addition of daratumumab, 92%. This is unprecedented in AL amyloidosis. The percentage of good hematologic responses, VGPR or better, was almost 80% with DARA CyBorD, which is also unprecedented. And also the rate of cardiac and renal responses was much, much higher, and we never see these rates of response in upfront treatment with daratumumab plus CyBorD. So I believe that daratumumab combined with bortezomib regimens will become soon the new standard of care for AL amyloidosis, particularly in patients who cannot be transplanted. So this is our approach. I think you will find this in the slides and in the recorded presentation briefly. Approximately 20% of patients can be transplanted. These are those who have low cardiac biomarkers. They can receive pre-transplant bortezomib if they attain a satisfactory response. There is no need to go on with transplant, I think, but this is our personal experience in Pavia. If a good response is not achieved after transplant, they can be challenged again with bortezomib. All the other patients can be treated with Cybor-D or BMDEX or melphalan dexamethasone if they have contraindication to bortezomib. But if daratumumab is accessible, this should definitely be associated with bortezomib-based treatment. We should keep in mind that black curve, this 20% of patients who are very high risk. These are treated with the same regimens as patients with intermediate risk disease, but with reduced dosages or introducing sequentially the therapeutic agents. We should not give up. We should not throw in the towel when treating our patients, because even in advanced stage patients, if they attain a deep and early response, then they can still enjoy an overall survival advantage. And what about relapse refractory patients? Well, first of all, I have to admit that we do not know what is relapse in AL amyloidosis. As you see here, there is a substantial disagreement between us experts of amyloidosis on timing of rescue treatment. And two different viewpoints have been published last year in Blood Advances. Personally, I think that patients should be treated early as soon as the free light chain increase, because small increases in free light chains can be associated with cardiac progression that is revealed by an increase of NT-proBNP. And when NT-proBNP increases, this is too late, because this is already associated with a very poor overall survival. But again, this needs an independent validation. For now, the cornerstone of treatment of relapsed refractory patients is immune modulatory drugs, particularly lenalidomide. You see here that the response rate varies from approximately 40 to up to 60%, with generally low rates of complete response. Importantly, in AL amyloidosis with proteinuria, lenalidomide can be toxic for the kidney. So you should be careful when treating patients with nephrotic syndrome with lenalidomide. Pomalidomide is generally more powerful. You can see response, hematologic response in 40 to 70% of patients. Almost all patients have some decrease in free light chains, and importantly, if you respond to pomalidomide even after alkylators and bortezomib, then you can have an increase in overall survival. Since IMiDs are the cornerstone of treatment of relapsed refractory patients, the combination of ixazomib or ixazomib has been compared to IMiDs and physician's best choice in trials. A phase 3 trial compare ixazomib versus physician's best choice. In most cases, lenalidomide dexamethasone has been run. Unfortunately, the primary endpoint, that was overall hematologic response rate, was not reached. However, responses were more profound with ixazomib in this study. Ixazomib can be combined with lenalidomide also in AL amyloidosis, as was reported in this nice but small retrospective study from the United Kingdom National Amyloid Center. They observed a 64% hematologic response rate with ixazomib, with more than 25% complete response rates. And there are other trials going on with ixazomib in AL amyloidosis. Venetoclax seems a targeted therapy in AL amyloidosis, since, as I have mentioned, the translocation 1114 is quite common in this disease. Unfortunately, due to the unexpected toxicity that was observed initially in multiple myeloma, we have not started trials with venetoclax in AL yet, but there are retrospective series. This is the largest one that I could find, and you see here that you can have good responses in the majority of patients, including some MRD negative response in AL amyloidosis, but this is only preliminary data. Once daratumumab was made available in multiple myeloma, everybody started using daratumumab in relapsed refractory AL amyloidosis as well. And this table summarizes the results that we have had so far. There are many studies. I just would like to emphasize the very high rate of hematologic response that we can have with daratumumab in rescue treatment when you compare this with what can be achieved with IMiDs. And also the organ response rates seem to be generally much higher than that we can usually achieve in the relapsed refractory setting. But if you look at the two bold rows that are related to the phase 2 trials that have been conducted in relapsed refractory patients, you see the very, very short time to response with daratumumab in this setting, which is very important in AL amyloidosis because time is life in this disease. And these patients attained hematologic response in 1 week, which is really very, very relevant for us. Now I'd like to go into detail in the largest retrospective series of daratumumab in AL and the 2 randomized trial. This is the phase 2 randomized trial of dara in relapsed refractory patients run by the Boston University group. You see here almost 95% response rates with 41% complete responses and 45% VGPR. These were heavily pretreated patients and toxicity was tolerable. We also ran together with Arnaud Jacquard, our friend, a trial in relapsed refractory patients. And the response rates in our experience were not so good, but still very good, particularly when we consider that in our French-Italian study, patients were excluded if they had achieved VGPR or better from after frontline treatment. So these patients were selected for a very refractory and stubborn, I would say, clone. And lastly, I would like to present you this retrospective series from the Heidelberg group, which is important because it is by far the largest series presented so far. Some patients were treated with daratumumab single agents, some with daratumumab and bortezomib. And you see that the rate of complete response, very good partial response, was very high, 55% with bortezomib and almost 50% with daratumumab. Again, the rate of heart and kidney response were very, very encouraging. And this was also a series that had been heavily exposed to previous treatment. The Heidelberg group remarkably noticed that patients with nephrotic range albuminuria had shorter event-free survival. This needs to be confirmed in other studies, and the Heidelberg investigators suggested that this could be due to losing daratumumab in patients with nephrotic syndrome. So in conclusion, this is a highly heterogeneous disease that demands that treatment be risk adapted. Once we have adapted treatment to the baseline risk, we need to be ready to change our approach, to change our strategy swiftly according to response. But response assessment is difficult, and as diagnosis, this should be done at specialized centers or with the assistance of specialized centers. But I am very confident and excited for the future because I do believe that the combination of chemo and immunotherapy will really be a game changer in this disease. And one more time, thank you very much for having invited me to this nice meeting. Thank you very much.
Thank you, Dr. Giovanni. Now we'll go to Dr. Hambali to present 2 cases about amyloidosis.
Okay. So actually, I have 3 quick cases just to discuss. Each case will have a different maybe message or challenge that we faced in these cases. So case number 1, this is an 82-year-old with heart failure. So basically, 82-year-old gentleman with past medical history of diabetes, hypertension, ischemic heart disease, who had CABG in year 2002. With also complicated with atrial fibrillation on warfarin and chronic kidney disease. He presented to the hospital emergency room complaining of progressive lower limb swelling over the past 3 days associated with exertional dyspnea. Physical exam showed bilateral crackles and lower extremity edema. On presentation, troponin T was 206, which was chronically elevated, and pro-BNP was 32,000. Creatinine was at the baseline of 200, around 200. 2D echo was done and showed moderately reduced LV systolic function with ejection fraction of 35%. There was sparkling myocardial wall, which raised the suspicion of an underlying cardiac amyloidosis. Then the patient underwent the technetium PYP scan, and the results were highly suggestive of ATTR cardiac amyloidosis. So the initial diagnosis was this is ATTR amyloidosis of the heart, wild type, but then was sent for hematology for further evaluation. And surprisingly, this patient had the following finding. The hemoglobin was around 10, platelet 80,000, creatinine were around 250 when he was seeing hematology. There was an IgG kappa of 13.1 gram per liter seen in the serum protein electrophoresis, and the serum free light chain showed elevated kappa around 2,350 with the ratio of 93. Of course, with the renal impairment, the beta-2 microglobulin was expected to be high. Now, because of the age and poor functional status, it was discussed with the patient and with the family the need to do further workup, but they actually declined. So they didn't want him to get a bone marrow biopsy or a skeletal survey. So the proposed diagnosis at this time was IgG kappa multiple myeloma, likely based on the protein electrophoresis and the serum free light chain. And the cardiac, what we have is ATTR cardiac amyloidosis. I don't know if Dr. Giovanni or Dr. Marty has any comment on this.
This is a increasingly common case. We see many patients who have a cardiac uptake at Centigraphy with bone tracers, and then they come out having a monoclonal component. As I briefly mentioned in my first presentation, this can be seen in almost 50% of patients who actually have an ATTR amyloidosis. So we don't know what type of amyloidosis it is in this case. In Pavia, we would have performed an abdominal fat aspirate. That is quite easy even in elderly people. And the sensitivity can be up to 80% in patients with AL-type amyloidosis. And then we would have characterized the amyloid on the fat tissue. And again, at this age, we also see many elderly patients who do not want to undergo heart biopsy. But maybe the fat could be positive if this is AL. The problem is that the light microscopy immunohistochemistry most often fails in discriminating between AL and ATTR amyloidosis. So we have a centralized network to do mass spec and immunoelectron microscopy, but this is what we will be going to see more and more commonly in our practice.
Okay. Also, another important issue about this case, which Dr. Marty can comment on, she sent me these slides.
Sorry, sorry, Amr, I would like just to add something on the previous cases. If we are talking about
the same case, Dania, yes.
Oh, it's the same. Oh, okay. Sorry. I just wanted to tell you that it was found also a mutation that it was described already in the. So not only he's old, but also he has most likely hereditary mutation of the HDTR plus the typical sign of the wild type, but it's not wild type actually. It's mutant. So it's worth to go to the family and see if their kids or the family has also mutant hereditary ATTR.
Okay. The same case, which you know, when I discussed with Dania, also it looks like these findings in the echo were seen since 2007, and she sent me the slides, which looks like it was, you know, with the repeated echoes, it wasn't picked up till the presentation when he came, you know. So sometimes it's important just to try to, you know, make the diagnosis as early as possible. These are the slides that Dania sent me. If you want to any comment on them.
And actually, which is nice, to be honest, on 2007, no one would wake up except unless he will do a BNP or something. The troponin would be most likely negative because the troponin is proof that there is cellular injury, whereas the BNP will be the stretch or like increased LV filling pressure. So the BNP will be higher earlier than the troponin. Troponin will be later. But I think in 2007, honestly, it was very, very difficult to do it, unless if you can do the next slide, Amr, with the one I told you, the GLS, the global longitudinal strain, which is earlier in the disease, will be decreasing. Even here, see in 2015, you can see the Sherry on top. I talked to you about it. In 2019 is -9. As I told you, 20% is normal, negative number, and now it's almost almost decreased, almost very, very low. But what we could not do in 2009, actually not 2007, in 2009 there is not the GLS, but something equivalent. I told you about the S prime, which is the longitudinal function. It was decreased with difference between the base and the apex. So if we are aware of it, we would have diagnosed in 2009 and the patient would have benefit from treatment.
Okay, very good. Let me just, for the sake of time, move to case number 2. This is suspicion. This could be also acute coronary syndrome. I don't want to just go fast here. Coronary catheterization was done and showed normal coronaries, and cardiac PYP was done and showed no scintigraphic evidence of PYP uptake in the heart. So she was transferred for hematology. Physical exam, interestingly, she had the classic features of AL amyloidosis with the periorbital hematoma. She had enlarged tongue and darkening of the skin. Pro-BNP was elevated as well as troponin. 24 urine protein showed around 0.5 gram. Creatinine was 71, and the SPEP showed the IgG lambda of 8.2, and light chain ratio was low at 0.017 with significant elevation in lambda. Bone marrow showed 20% plasma cells, IgG lambda Congo red negative. So it was diagnosed as IgGL multiple myeloma with secondary AL amyloidosis. She was started on the VCD, which is the main regimen that we use in our center for myeloma. We use the same induction therapy. Unfortunately, she had very poor tolerance to therapy. She had multiple admissions, multiple times for decompensated heart failure. And in 4 months, we managed to give her only 2 cycles of VCD. And her performance status right now is 3 because she's just losing weight and fatigued, and because of the heart failure also. And she's off therapy right now. The interesting part is with the 2 cycles of VCD, she normalized her lambda chain. But of course, if you look at the troponin and pro-BNP, they continue to be elevated with spikes in every admission she goes to the hospital. So I don't know if there is any suggestions for this case at this point.
Yes, you know, and BNP can be fluctuating also due to the fluid retention status. So it is very difficult to treat these patients. Sometimes even very low undetectable levels of free light chains can sustain cardiac damage. But I agree, given the low concentration of free light chain, I totally agree with your watchful waiting approach.
Okay.
Being ready to start treatment if the patient improves, but not enough to be satisfied.
Great, and that will conclude my cases.
Okay, thank you, Dr. Hanbali.
Okay.
So for the sake of time, we have 6 questions. Question number 1 to Dr. Giovanni. So what's your basic lab you order in patient you suspect AL amyloidosis at your center? So what usually do you order?
You mean what kind of tests?
Yes.
Yes, well, the first step is looking for a monoclonal component, because the diagnostic pathway of AL and non-AL amyloidosis are different. AL is a medical emergency. And you really don't need scintigraphy, for example, if there is a monoclonal component, because you have to go straight to biopsy. So what we do is serum and urine immunofixation and measurement of circulating free light chain. And actually, I do not even wait for patients to arrive at our center, but I order them at home so that I can schedule in advance the different tests that you need for AL and non-AL amyloidosis. If I know that there is a monoclonal component, the first time I see the patient, I do echo, I do cardiac biomarkers, of course, biomarkers of organ dysfunction. In most cases, I also do cardiac MRI and cardiac scintigraphy with florbetaben. That is a tracer that localizes specifically to the heart, but this is investigational, and I do not use these results for treatment. And of course, echo. And then I start with abdominal fat aspirate. And I want to have the result of the Congo red stain very quickly. If there is amyloid, I do typing with immunoelectron microscopy, because it is in our hands, it is faster than mass spec. And only in 1% of cases, I need to do mass spec. That is, we do approximately 50 mass spec in Pavia and 500 immunoelectron microscopy per year. And that's all. If I don't find amyloid, then I schedule a organ biopsy.
So another question to Dr. Baladini. Does psychogenetic impact your first line of therapy?
Yes, in a way it does, but not systematically, because there are other concerns. For example, if I see that a patient has a translocation 11-14, but the patient is transplant eligible, or I think he or she may become transplant eligible, I do not use oral melphalan. I prefer to use a second-line transplant if the response to CyBorD is not enough. If a patient is older, so there is no way I can transplant the patient, then if the translocation 11-14 is there, I prefer using oral melphalan. And if the patient has the gain 1q21, I use CyBorD. So basically, the difference is for now is choosing between BMDEX or CyBorD, and I would say 30% BMDEX, 70% CyBorD. If CyBorD doesn't work, and I did use it, it is because I was expecting transplant, and then I do transplant second line. Italy is very slow in having drugs up front, so I am waiting for daratumumab. Paradoxically, I provide consultancy for patients who are outside the European Union, and I was able to use data upfront in these patients because before I could do this in my own patients.
In non-transplant eligible, do you prefer continuous therapy or just limited time therapy?
So, sorry, can you repeat, please?
So in patient who is not candidate,
I do not do maintenance. I go to a plateau of response. I consolidate 2 cycles and then I stop.
okay. So another question, is it common to have mixed response like by organs, like one organ improving, the other is worsening?
Of course. You see it most times because there are different speeds of organ recovery. When treating patients at the beginning, you shouldn't look at organ response. You just be satisfied. You should just be satisfied with a hematologic response. If you have a deep hematologic response, then you start thinking of organ response after 6 months. The heart is the quickest. The kidney can be quick, but sometimes you need to wait up to 1 year to have organ response. So really, I do not use much organ response to design my early treatment strategy.
So the one question about how, like in patient who's not a candidate for a transplant because of cardiac amyloidosis, and then you have some hematological response by bortezomib-based therapy, how long do you wait for cardiac recovery before you said maybe patient now is a candidate for a bone marrow transplant?
Well, it depends on the quality of hematologic response. If I have a complete response, I wait 6 to 9 months for the heart to improve. If the heart doesn't improve, I do MRD. If the patient is MRD positive, there is no sign of heart improvement, and the patient is fit enough, then I do some more anti-clone treatment. If the heart improves in complete response, I do not do any other type of treatment because I already have organ response, and the overall survival, even long term, is very, very good for these patients. If I don't attain complete response and I do know that the clone is still there and the heart improved but not completely, then I can consider stem cell transplant.
Okay. So any promising data about the antibody, the NUD001, any rule?
No, unfortunately not. This was a failure. We were deeply and sadly disappointed by the results of the clinical trials. There was much effort from the company, but also from the academic world. We only invested much time and effort in this study. But as you know, this was closed for futility. There was a report at the ASH meeting last year about some signal of of better outcome, slightly better outcome in patients with Mayo 2012 stage 4 treated with this antibody, but this was just a small signal. However, I know that the company is considering some more investigation on this.
Okay, so the last question will be to Dr. Dania. What are the genetic tests available at Kingdom of Saudi Arabia? So what's the genetic test you perform?
Actually, I had a question on live that I will respond. Some people understood that the genetic test should be done to differentiate between TTR and light chain. It's not. This is not the case. Actually, we do genetic testing only to differentiate between wild type TTR and hereditary TTR for the MAP screening. It doesn't play a role for the light chain. The light chain is biopsy and biomarkers and the workup for gap-mapathy monoclonal. So what's available is we know that there is a gene, the chromosome 18, and actually what we do in King Faisal in the whole exome sequencing gene. So we discover 3 new mutations that are not described in the literature, and we are in the process of publishing this paper, in addition to some other mutations that were found already described in the literature. So in King Faisal Hospital, we can do all type, the whole exome sequencing, genome sequencing. So it means you take the DNA of the patient and you can, we're looking for the main type of mutation, but also new mutation or de novo. Now for the whole Kingdom of Saudi Arabia, I don't know, but I know that Riyadh is sending for us. Honestly, I cannot talk about Medina, about Jeddah. Most likely, they might have a genetic laboratory or lab test, but usually I was told that it's sent to us. I would like just to add something that Dr. Giovanni told about the cardiac response. We used to receive many people asking for another echo to see for the cardiologic response. Please do not expect in 6 months or 3 months that the thickness of the heart will decrease. As he told you, the toxicity of the light chain will decrease if he responds hematologically, but what we can expect is the total decrease of the BNP or very decrease of the BNP level. This is a sign of cardiac response. And the NIHA class, of course, the patient will improve very much. And the other sign what you have done is small study about the GLS. The strain will improve by 2%, 3%, which is good. But the ejection fraction and the wall thickness will not change, even though the patient will be better. So do not ask for echo to see if the patient will respond to your treatment, at least for the first 6 months.
Okay, thank you very much. I really appreciate Dr. Giovanni, Dr. Mohdi, and Dr. Amr Hanbali for their presence. Just to know, this webinar is fully recorded, so you can go on YouTube and find the full record of this webinar. And please join us on the next webinar that will be held on 30th of November. Thank you very much, and I appreciate your presence. Thank you.